The sun rises over the San Joaquin Valley, California. This week, the coronavirus is all over the internet. The official name is COVID-19. As of February 27, 2020, over 80,000 people are estimated to be infected with coronavirus worldwide, with about 2,700 deaths. It is spreading fast. There are 60 confirmed cases of COVID-19 in the United States, with no deaths being reported so far. The coronavirus story is developing as I talk right now. In the meantime, there are about 40 million people infected by influenza A and B. Yes, 40 million, which have caused about 40,000 deaths around the world. Headlines about influenza A and B are less common these days.
Welcome to Rio Bravo Q Week, the podcast of the Rio Bravo Family Medicine Residency Program, recorded weekly from Bakersfield, California, the land where growing is happening everywhere. The Rio Bravo Family Medicine Residency Program trains residents and students to prevent illnesses and bring health and hope to our community. Our mission is to seek, teach, and serve. Sponsored by Clinica Sierra Vista, we are providing compassionate and affordable care to patients throughout Kern and Fresno counties since 1971.
Hello everyone, this is our first episode of Rio Bravo Q Week podcast. Today is February 27, 2020. This episode I have called the Limping Embryo. An embryo is the elemental stage of an organism which evolves into a baby and then becomes an adult. This is the first episode of this podcast, which is the embryo episode. And hopefully this is going to be the embryo of many other episodes that will come in the future. But why is this a limping embryo? I invite you to listen until the end to find out. First, let me introduce myself. My name is Hector Arriaza. As you can tell, I was not born in Minnesota or Oregon, and I'm reminded about it frequently when people ask me, "Where are you from?" The answer to that question is not that easy, but I'll try to keep it simple. I was born and raised in Venezuela, in South America, or how some people may call it, one of those Mexican countries. Well, not really a Mexican country, it's another country, it's in South America. I graduated from medical school in Venezuela. When I was 24, I decided to come to the United States to serve as a missionary in Salt Lake City, Utah. Then I went back to Venezuela for a few months and returned to the United States, searching to further my education in a residency program. After spending some years as a Spanish translator, I found a residency spot in Bakersfield, California. This is where we are right now. And I completed a residency in family medicine. I practiced primary care in a community health center for about 1 year and a half. And Dr. Stewart, who is the program director of my residency program, offered me a position as a faculty member in the very same residency program I graduated from. It has been over 1 year and I'm loving it. This podcast has been created to promote teaching and learning among residents, medical students, and faculty, and whoever listens to us wherever you are in the world. I hope you can enjoy it.
What we know is a drop. What we do not know is an ocean. Isaac Newton.
What we know is a drop. That little drop of knowledge that we know is becoming larger and larger over time. Medicine has experienced many advances recently, and it is complicated to keep up with all the knowledge available to us. The idea of this podcast is to provide some traces of knowledge, maybe a mini micro drop to complement your study during your residency. During this podcast, we will focus on 5 questions. A different guest will be invited to participate every week, and I will conduct the interview. The questions are: question number 1, who are you? The person being interviewed will have about 20 seconds to introduce him or herself. Question number 2, what do you learn today? Any topic is valid. The interviewee will explain what he or she learned. Some additional questions may be asked to clarify the topic. Question number 3, why is that knowledge important for you and your patients? Or, in other words, practical application. Question number 4, how do you get that knowledge? To explore learning habits. And question number 5 will be, where did that knowledge come from? Is to cite the source of the information. So, because this is our first episode, I want to follow the same pattern which I have established for the podcast. With the question number 1, who are you? And I already answered that question. So, question number 2, what did you learn today? So today I would like to talk about toxic synovitis. Toxic synovitis is the most common cause of acute hip pain and limp in children ages 2 through 12. Irritable hip is a non-specific term referring to acute limping, hip pain, and stiffness, which may be used in clinical practice instead of toxic synovitis. Toxic synovitis is a term that can be confusing for patients or even professionals who are unfamiliar with this condition because it has nothing to do with a toxic state or a toxic appearance. Other names for this condition are post-infectious arthritis, transitory coccitis, coccitis fugax, acute transient epiphysitis, but in general, a very appropriate term for this condition is transient synovitis. It is transient because it is self-limited. Inflammatory disorder of the hip, typically the hip, but it may affect other joints. Affecting young children between ages 2 through 12, more commonly boys. The presentation is very typical. It presents with a mild to moderate hip pain and limping with a history of recent upper respiratory infection, such as runny nose, cough, fever, the normal upper respiratory infection that you see in the clinic. But this condition might not always be present. You might have hip pain without the upper respiratory infection. And it can be any kind of any kind of viral infection, It can be rubella, parvovirus B19, Coxsackie virus, but it has to be extra-articular viral infection. The patient normally keeps his or her hip in abduction, remember AB, abduction, and external rotation. Hip motion may be limited, but the patient will usually allow movement through a limited arc of motion. Normally, the patient will be able to bear weight. So when you have this patient in the clinic, you have to evaluate to determine if this is toxic synovitis or something else. So history and physical exam are very important. Remember, physical exam is always the base of your diagnosis, or it helps you with the diagnosis. And the findings include hip pain, of course, and the hip pain is increased by movement, and there are no external signs of inflammation. After you have examined the patient and you notice that there is pain with flexion of the hip or with movement of the hip, then you might need to do some labs. And labs may include a complete blood count, erythrocyte sedimentation rate, and C-reactive protein. However, they are usually normal. Lab studies may be ordered to rule out other causes of hip pain, especially septic arthritis, which is very important to rule out. So if you are still unsure and you want to do an X-ray, it's okay, but normally you don't need it to make the diagnosis. X-ray of the hip is normal. There is no specific findings for this condition, toxic or transient synovitis. However, you can have minor changes, such as early radiographic signs, such as capsular distension, joint space widening, decreased definition of soft tissue planes around the hip, or slight demineralization of the bone of the proximal femur. The primary role of plain radiograph is ruling out other disorders. Ultrasound may detect joint effusion, and absent joint effusion rules out septic arthritis. So that's why it's important to have point-of-care ultrasound. And I'm glad that we are growing in that aspect. Ultrasound of the hip can help you detect joint effusion, and absent joint effusion rules out septic arthritis. That's why it's important to have point-of-care ultrasound. And I'm glad that we are growing in that area in our residency. So you have to make a differential diagnosis. And the number one differential diagnosis has to be septic arthritis, the most important condition to rule out. Septic arthritis presents with toxic appearance, the hip pain is more intense, and elevation of inflammatory markers is present. So there is 4 elements that you have to take into account when you're thinking about transient synovitis or synovitis. And those elements are number 1, fever, number 2, weight bearing, number 3, ESR, and number 4, serum white blood cells. So to be transient synovitis, these 4 elements have to be present. Fever below 101.3 or below 38.5 if you're using Celsius. Child or the patient has to be able to bear weight. The ESR or the erythrocyte sedimentation rate has to be below 40 millimeters per hour. And the serum white blood cell count has to be below 12,000. So if you have these 4 elements, the risk of having a septic arthritis is less than 0.2%. But if you have one of those elements, the prediction is about 3% of risk of septic arthritis. So remember those 4 elements: fever, weight bearing, ESR, and serum white blood cell. Other diagnoses that you have to consider are conditions that are less common, such as Lyme arthritis, a late manifestation of Lyme arthritis, osteomyelitis, Legg-Calvé-Perthes, and that pronunciation is questionable because there's many ways to pronounce that condition, but it's the Legg-Calvé-Perthes, pyogenic sacroiliitis, juvenile idiopathic arthritis, and of course fractures and tumors. Something to consider also when you have a kid with hip pain is to rule out abuse, because it can be a sign of abuse in children too. And I'm talking about physical abuse. The treatment for this condition is basically to avoid movement or to have activity restrictions and to use NSAIDs as needed. Recurrence is not common, and observation in hospital may be needed if there is a need to rule out septic arthritis. I recommend that you follow up with these patients in 7 to 10 days to make sure that the patient is improving, that the pain is improved. And I just want to give you a reminder: transient synovitis. Transient synovitis is uncommon in adults. It is more common in fall and winter, which is the specific time when we have more colds or more viral infections. And it's less common in African American children. And rarely it is bilateral. And if it's recurrent or persistent, it may be the initial sign of a chronic inflammatory condition such as juvenile idiopathic arthritis. So now we're going to do to question number 3. Why is this knowledge important for you or for me and my patients? As family medicine physicians, we encounter all kinds of complaints across all ages. Knowing how to approach hip pain in children allows you to provide appropriate and timely treatment for your patients. Misdiagnosis of hip pain may cause serious consequences to your patients, including permanent disability. So I just remember having a patient with hip pain when I was moonlighting in one of the clinics in Lamont, and I remember I was considering septic arthritis, and I had to give a call to Dr. Rao, and thankfully Dr. Rao helped me with that patient. But using your clinical judgment to decide on the appropriate laboratory studies and imaging in hip pain allows you to practice cost-effective and accurate medicine. Question number 4, how do you get that knowledge? Well, I got interested in this topic because of an email that I received from the New England Journal of Medicine titled Question of the Week. So it was all about the transient synovitis. So that's why I got interested in that topic. And Question number 5. Where did that knowledge come from? After answering the question of the week from the New England Journal of Medicine, I went deeper into that topic by reading the abstracts of the citations mentioned in the question. And these are the authors, John J. and Chandran L. The topic was arthritis in children and adolescents, and it was published in 2011. And also I read Huntley, J.S., Diagnosing and Managing Hip Problems in Childhood, published in 2013. You can see the details in our website. I also consulted Online Hippocrates, which is a handy resource when you need a rapid review of a certain topic. Remember, trends in synovitis is a diagnosis of exclusion of hip pain in children after an upper respiratory infection, especially in kids between the ages of 2 to 12. And now you know why this episode was called the Limping Embryo.
Speaking medical. The medical word of the day is sphenopalatine ganglioneuralgia. Can you guess what that means? Wow, what a mouthful, huh? A mouthful of ice cream, that is. Sphenopalatine ganglioneuralgia is a medical term for brain freeze. The sphenopalatine ganglia is the largest of the 4 parasympathetic ganglia associated with the trigeminal nerve. It consists of the largest collection of neurons in the head outside the brain, a mini brain, if you will. Sphenopalatine ganglioneuralgia is not considered a disease. Vasoconstriction causes a brief alteration of blood flow to the brain, causing an acute spasmodic pain of the nose, orbit, base, and head. It's likely the brain's defense mechanism to ensure abrupt changes in temperature don't occur. What's the treatment? Stop shoveling ice cream in your mouth. Sphenopalatine ganglioneuralgia.
Next we have, for your sanity, our medical joke of the day.
Alisa, how do you hide a $100 bill from a family medicine resident?
How?
Well, you put it in the in-basket.
Okay, Roberto. And how do you hide it from a radiologist?
I don't know. I guess you put it in a dark room?
It's a good answer, but no. You give the dollar bill to the patient.
Oh. Alisa, and how do you hide it? How do you hide the... Okay, just cut it.
Yes,
okay.
go ahead.
Alisa, and how do you hide the $100 bill from a plastic surgeon?
I have no clue.
Yes, you're right. You can't. You can't hide money from a plastic surgeon.
And now, Spanish, por favor, our Spanish word of the day.
Hi, my name is Dr. Rava, second-year resident, and I'm here to teach you some Spanish. The Spanish word of the day is coyuntura. Coyuntura actually means joint, the type of joint that are made out of bones, okay? The definition of joint is a structure in the human or animal body at which 2 parts of the skeleton are fitted together, coyuntura. Coyuntura is a common word among the elderly, although it's not uncommon to hear it from younger people. People may use this word while explaining any pain in any joint. As an example, your patient may complain saying, "Doctor, me duelen las coyunturas." This translates, "Doctor, my joints hurt," meaning most of their joints are hurting. Although, they may also refer to a particular joint such as the hip or the knee or any other coyuntura. Now you know the Spanish word of the day, coyuntura, and you know what it means. All you need to do now is to assess your patient's coyunturas. Thank you.
And that's the end of Rio Bravo Q Week. We say goodbye from Bakersfield, a special place in the beautiful Central Valley in California, a land where the growing is happening everywhere. If you have any feedback about this podcast, please contact us by email, rbResidency@clinicasierravista.org, or by visiting our website, rbfmrp.org/podcast. This podcast was created with educational purposes only. Visit your primary care physician for additional medical advice. Our podcast team is Dr. Hector Ariaza, Dr. Lisa Manzanares, Dr. Roberto Velasquez, Dr. Elisa Dermogerdichin, and content review is provided by Dr. Carol Stewart. See you next time.